hopefully, might be worse. So I was asked to do this talk, and I kind of thought, well, I don't really do that. I don't really do ECMO in thoracic surgery. I use ECMO in lung transplant, but my initial thought was I don't use it in thoracic surgery. And then I kind of thought through some patients we've had recently and thought, oh, well, I do it sometimes, and I kind of guess I do. And then actually, by the time I'd gone through the talk, I thought, maybe I should be doing it more. So hopefully you'll all think that by the end of it as well. So, as you know, respiratory failure is now the third cause of death in Europe. Patients with acute respiratory failure, mortality remains around 40%. So the idea is that with a transitory lung or heart-lung support technique, you can have a life-saving technique. General thoracic indications, so the majority of them are still around lung transplantations. Lung transplantation accounts for 90% of thoracic indications. And lung transplant, as you know, is used as a bridge to transplant with or without mechanical ventilation, so ideally with patients awake on ECMO. It's used intraoperatively, either for hemodynamic instability, or in some patients. So we have a cohort of patients with pulmonary hypertension who their pulmonary pressure is so high that we can't have them anaesthetized prior to surgery. So in those patients, we go on ECMO with them awake at the beginning of the operation, and then they have their anaesthetic after that. The most common use in transplant is probably still post-operative support in patients who've got primary graft dysfunction post-operatively. And then the other growing group of patients for ECMO, obviously, is patients with ARDS for various other reasons that they've got lung injury. And then for the thoracic surgery group, I guess it's split into patients who are already on ECMO preoperatively, who use ECMO as an intraoperative mechanism, and those who go onto ECMO post-operatively because of respiratory complications. So I'm sorry for some people this is going to be kind of quite basic, but just to go through the basics of an ECMO circuit. So it's a pretty simple circuit. When you're describing it as VA or VV, the first letter of that is the outflow line, so that's the drainage system. The blood then goes through a gas exchanger, an oxygenator, with a heat component to that. You may or may not have a pump. So if you're doing a system that comes out from the artery, so an AV system, that doesn't require a pump because the patient's blood pressure will pump it through. And those little pumpless systems are used in patients where they've got respiratory failure due to high CO2. The other kind of specialised use of those is in patients with pulmonary hypertension who are usually listed for transplantation but don't have a transplant yet, and those patients can have one of the little AV systems put in as a pulmonary artery to left atrium, but that's a fairly specialised use. And then the cannula is the inflow system after that. So that's the second letter of the description. The anticoagulation varies with type, but basically it's always less than you would require for bypass. So for the little AV system, it's really just a heparinized system, and patients aren't heparinized formally for it. For even going up as high as a VA system, the ACTs tend to run about 180 or to 220, which is significantly less than bypass. Just to go through some of the basics of the oxygenator. The oxygenator is an interface membrane between blood and your gas flow that you're putting into the system with it. The blood flow obviously coming out, the patient has low oxygen and high CO2, and the gas flow on the other side has high oxygen and no CO2 on the other. And then if you think back to the oxygen and CO2 dissociation graphs, then the oxygenation is controlled by the blood flow. So the blood flow allows the blood to take up the oxygen from the gas, and the saturation is dependent on the flow in the pump. So you need a high flow to be able to fully oxygenate the patient. Whereas with decarboxylation, the rate of decarboxylation is dependent on the sweep of the gas going through the system, and that eliminates your CO2. So for decarboxylation, you can have a low or a partial bypass system with only 20 to 30% of blood volume going through it, and that will very effectively decarboxylate the patient. So the types of ECMO is split into different levels, and they're pretty much going up on the how severe the ECMO is, how much you need, how much support you're applying. So level A is often that little Nova lung system, which I'll show you some pictures of in a bit. That's an arteriovenous system. So the artery is as used as the pump, so it's a pumpless system. And there's also now the little ultra mini ECMO machine as well. Level B is one stage higher, so that's veno-venous with it, and that will give you full oxygenation of the patient. And one of the common cannulas used for that now is the Avalon cannula, so the single station jugular cannula. And then you're going right up to level C, which is veno-arterial, so the drainage is from the venous system pumped into the arterial system, and that gives you hemodynamic as well as respiratory support. And that really is kind of into a parallel lung support system. So basically this is the same. I find this diagram works for my brain, so I thought I'd show you that. So this is how I kind of think through which bypass, which ECMO system I'm going to use. So the first question is, are they in hypercapnic failure alone or hypoxic failure? So if they're in hypercapnic failure, but they're hemodynamically stable, then the level A support is adequate for them, and that's the AV pumpless system. If they're hemodynamically unstable, then they move to support level C, because that's the only one, that's the VA system, and that will give them hemodynamic stability, which the other two won't. And then for hypoxic failure, but in a hemodynamically stable patient, it's support level B, which is the VV, and quite often that's that Avalon cannula, and that's pump driven as well. There's a lot of different options, which I think is why at first sight it all looks very confusing, but it just is that there's lots of different ways of doing it. There's lots of things that are all correct. So you can centrally cannulate or peripherally cannulate, and that will depend on what you're doing. So if it's an intraoperative and the patients become unstable while you're operating on them, then you probably could go for central cannulation. If it's a planned cannulation, then even if you're planning it as an intraoperative support, you'll often do it peripherally, because then the lines aren't in your way during the operation. Many of them are put in now percutaneously, and often some of them are still put in surgically. The advantage of the percutaneous is you probably get less bleeding, which is nice, particularly in the VA system when you're having a higher level of anticoagulation for the patient. The implantation sites are, again, many. So your peripheral implantation sites include the femoral vessels. Just as a point, the right side is the easiest one to do, so go for that one first if you have the option. With the femoral artery, you have a risk of distal ischemia, because you've got no blood then going down the limb. So you need to have, if you're on bypass with those, on ECMO with those patients for more than an hour to 2 hours, you need to have a reperfusion shunt to give blood flow to the limb and stop distal ischemia. Or what our preference is a T graft. So I'll show you a little picture of one of those. An auxiliary approach, again, you'd use a prosthesis for that. That's a very good approach. It gives very good oxygenation to the coronary arteries as well. And then the jugular and the carotid vessels in the neck can all be used. So often in patients, what you're wanting to do is support them through a period of respiratory compromise, and having them awake is obviously the best way of doing that. So as I say, we use an awake system just as a special one for pulmonary hypertension, but many of these systems can be put in patients when they're awake, which would be the ideal way of doing it, especially if you're doing it in people for support post-surgery when they're running into trouble. If you could get them onto a small, simple ECMO system without having them ventilated, then that would be the ideal. And certainly many of the cannulas, and including the Avalon cannulas, can be put in awake. So just to give you some a guide to the different support levels. So this is support level A. With it, you can see, can I move that onto here? You can see the little Nova lung system. So it's a very small little box that can be used very easily with it. It, as I said, will only give you, reduce your CO2 with it. You may find that you've started off with that and then you need to go up a level in your support, but that's quite a neat system for it. The support level B is includes the Avalon cannula. It's not just the Avalon cannula, it's venous to veno system, so you can have a combination of, but it's basically draining venous and the oxygenated blood is going back into the venous return side. It is the most common mode used for primary lung failure. And the Avalon cannula, as you can see on that diagram, is draining from the SBC and the IVC, and then the blood is returning to the right atrium into the right ventricle. And for that system, there's no hemodynamic support, so you need a good heart function for it. Level C is the one where you get hemodynamic support as well. That's really a full support system, and the oxygenated blood gets returned to one of the major arteries. I just really want to point out to you the options for a retrograde cannula. So on the slide, the picture furthest away from me is a small percutaneous cannula giving blood flow back to the limb. And this is a system that we've kind of favoured, where there's a Dacron graft onto the femoral artery, so that allows blood flow to go to distally as well as back into the return system. So the indications in thoracic surgery. So I think the first one is probably the one that I end up seeing patients with. So it's patients who are admitted with acute respiratory failure for some other reason and then run into trouble that requires some sort of thoracic intervention, and they're already on ECMO support when they come to theatre. The second ones are intraoperatively, so they can be used as an alternative to in-field ventilation or full bypass, and that's mainly in tracheobronchial surgery or single lung procedures on patients who are undergoing complex procedures that have had a previous pneumonectomy, or indeed patients with tumour invading into the great vessels or left atrium. It also can be used intraoperatively to provide respiratory support when patients are struggling due to respiratory insufficiency on one lung ventilation. And post-operatively, it's a good mechanism to reduce or avoid mechanical ventilation in patients who are struggling. So I just very quickly go through one of the patients that we had. We had a 32-year-old male who was admitted to our centre. He was crushed between two trucks and had extensive chest and spinal injuries from that. He was intubated, ventilated, had bilateral chest drains put in. He had a large air leak on his chest drains. He was put onto VV ECMO for respiratory support and managed in, we're the ECMO centre, and the intensivists were managing him on the intensive care unit for some days with an unresolving massive air leak. And then at that point asked my colleagues to see the patient, and this was the CT scan of it. So he's got bilateral pneumothoraces despite, I think, about 4 chest drains in at this point. The right airway couldn't be seen and a huge pneumomediastinum. So on day 3, he had bronchoscopy, which showed very clearly a tear in the right main. He was taken to surgery and had right pneumonectomy and repair of his right main on full VV ECMO support. At that point, my colleague went on holiday and said to me, "I'm not sure about that stump, would you just keep an eye on him?" And 2 days later, huge air leak again with it. And he had complete dehiscence of his right main stump. And also, by that time, you could see there was partial disruption of the carina and the trachea. So we took him back to theatre. He's still on VV ECMO, thank goodness, and inserted covered stents from around the distal third of the trachea right down into the left main. From that point on, he settled very well and returned to theatre a few days later for spinal fixation, and then returned around day 12 when my colleague came back from holiday for a combined case with plastics to put a flap into that pneumonectomy space. And this is early chest x-ray with his venous cannula still in place and stents all the way down. So we removed his stents. It was Boston covered stents that we'd put in. We removed his stents prior to his discharge, and actually the whole airway was healed and very nicely intact. And he's made a complete recovery and is back at work. So it was a very nice ECMO story. It's the one I've decided to use. This is a review of the French experience. So this was the national ECMO used in thoracic patients in France over a 3-year period. And they had 36 patients, 20 had VV ECMO and 16 had VA ECMO. Of those 36 patients, 28 of them were undergoing elective surgery for either tracheobronchial surgery or for single lung procedures. 5 patients had respiratory insufficiency intraoperatively and were put onto ECMO, and 3 of them were on preoperative ECMO for ARDS and came to theatre for another reason under the thoracic surgeons. So looking at their complications, as you would expect, the 30-day mortality is pretty good in the tracheobronchial and single lung group at 7%. When you get into the patients who became unwell in theatre and were put onto ECMO in theatre, then that's up to 40%. And then, not surprisingly, because they're a difficult group, the ones that are on ECMO preoperatively for ARDS was 75%. 2 of the patients actually in the group 1, so the ones that were undergoing surgery and had the support of ECMO for it, required prolonged ECMO and had their VA system converted to VV for chronic respiratory compromise, but then weaned successfully. 17% returned to theatre for bleeding, and 2 patients had cannulation complications. So in summary, I think there's been a huge technological advance in ECMO. It's great to have percutaneous cannulation of patients. I find peripheral is certainly easier to manage with patients usually than central. There's multiple choice approach for different situations. I think just looking at all the options and working out which one you think suits your the place that your patient is in at that time. You can go from partial to total support, and you have to have a little bit of plasticity about it and be prepared to change from one level to another as the patient's dynamics change. But it's a great way of avoiding high volume traumatic mechanical ventilation. However, its use remains fairly exceptional, I would say, but it can provide total respiratory support for complex surgery where conventional techniques are felt not to be feasible or you don't wish to use them. And I think overall, probably, certainly in my practice, should be considered more in respiratory patients who run into respiratory failure post thoracic surgery. Any questions?